The article today showcases the improvements which has been achieved by the Ministry of Health and Family Welfare in the field of immunization and the impediments which still persist and thus kind of block the idea of achieving universal health coverage, which forms an important component of your GS2 paper under the larger theme of health and governance. So the first question which shall arise in your mind shall be that does there exist any historical precedent to the existence of such vaccine in our ancient India? The answer is a very interesting yes and no at the same point of time. So for example, the Charak Samhita, which basically dates back to 6th century BC, so it was being written in the contemporary period of the development of Mahajanpadas. It basically mentions certain ingredients which can actually be utilized to boost your ojas or immunity. However, it does not specifically anywhere mention any kind of vaccine. So a follow-up question can be, what are vaccines? It is basically a process of utilizing various kind of microorganisms or inactivated pathogens or genetic materials like for example messenger RNA to actually create antigen. Antigen which is basically going to fight with the pathogen which was going to impact our body and thus kind of have a detrimental impact on our health. The first mention of such preventive inoculation in writing actually comes from 16th century CE in the region of China, where they have described certain treatment procedures for smallpox. However, the first evidence of development of such vaccine to treat smallpox was actually developed in the year of 1796 by a person named as Edward Jenner. Keep this in mind that such vaccines which are being developed in the scientific lab actually requires long gestation period, large scale capital investment as well as a long research procedure of trial and error, and thus it ultimately transitions to large scale mass production. Thus, it approximately took 57 years for the development of the first smallpox vaccine, which actually started being produced at a large mass scale, and it was actually made mandatory in UK in the year of 1853. Then, in the year of 1885, there came a Frenchman, Louis Pasteur, who actually developed the first live virus vaccine to actually treat rabies. Then you guys can recall from your modern history lecture that how in the year of 1897 there was a bubonic plague which has engulfed the region of Pune, Maharashtra, and how for that purpose there was an appointment of a Rand Commission whose chairman W.C. Rand was actually executed by the Chapekar brothers because of the kind of the negligence towards the health of the people as well as the number of atrocities which they had committed in the time period of this plague in the region of Pune. In the very same year, 1897, there was Valdemar Haffkine who actually developed a vaccine for the cholera. In 1922, further vaccines were developed to actually treat tuberculosis, diphtheria, tetanus, etc. And in 1944, the first vaccine against the flu was developed. The first genetically engineered vaccine was actually made for hepatitis B and the year was 1986. So with the establishment of the World Health Organization in the year of 1948 on a specific date of 7th of April, the idea of universal health coverage to actually create such large scale vaccination to treat large amount of disease and thus focus on the preventive healthcare rather than curative healthcare, that actually came into prominence. Keep two things in your mind from the prelims perspective. First, the 7th April is also celebrated as World Health Day, and World Health Organization is a specialized United Nations agency which is headquartered at Geneva, Switzerland. So this concept, which was being discussed at a lot of international forums, the universal health coverage, led to the signing of Alma Ata Declaration of 1978, where it basically propagated the idea of health for all. And it also reaffirmed that how strengthening of the primary health care centers are sine qua non or prerequisite to actually achieve this idea of vaccination. Thus, on this line, they actually set up a target to provide such universal health coverage to each and every people across the world by the year of 2000. Just by having a look at the number of people who are suffering from various diseases, just like how Gautam Buddha did at one point of time. You guys can also assess that this idea of Alma Ata Declaration of 1978 has not come into fruition. Thus, when the United Nations Sustainable Development Goals were being designed to be achieved by the year of 2030, there was an inclusion of a specific goal, that is the goal number 3.8.1, which now aims to provide essential health services to all the people across the world by the year of 2030. And in this direction, there also has been signing of a global action plan or GAP for healthy lives and well-being for all by the year of 2019. To actually achieve this idea of universal health coverage, to provide such large-scale immunization to people, and to actually focus on the preventive healthcare concept, the World Health Organization has launched expanded program on immunization, where it actually puts impetus on the increased coverage of three bacterial diseases: diphtheria, pertussis, and tetanus. And keep this in mind that coverage for such bacterial disease and various other diseases which are actually preventable from the vaccine uses, the coverage has been increased from being a meager 5% of the population in the year of 1974 to approximately 85% by the year of 2024. If you will actually visit the World Health Organization's website, they also basically showcases the achievements under this expanded program on immunization. That how smallpox has actually been eradicated from the world by the year of 1980. The journey which started from the year of 1796 when Edward Jenner actually developed the first smallpox vaccine. Or how in the case of polio, the World Health Organization has been able to achieve almost 99% polio eradication. Right now, it is endemic only in two countries, and that is Pakistan and Afghanistan. Or the kind of the joint efforts where a lot of countries actually put a lot of resources, a lot of joint research programs, and developed a lot of vaccines under the global vaccination efforts for COVID-19. In this direction, following the idea of Vasudev Kutumbakam, our country also basically launched an initiative, that is Vaccine Matri, where we actually delivered COVID vaccines to almost 95 countries at that point of time. Also, to actually further expand the coverage of immunization, the World Health Organization has actually come up with the Immunization Agenda of 2030. Read the points very carefully from the perspective of prelims. First, the idea is to reduce by 50% the number of children who are missing out on all the vaccine. Second, to actually achieve 90% coverage for essential vaccines which are actually given in the childhood and the adolescence. And then to actually introduce 500 new vaccines in the low and middle income countries. Following the template of this expanded program on immunization by the World Health Organization, our country basically designed the Universal Immunization Programme. So first, when it was launched in the year of 1978, the name was Expanded Program on Immunization, borrowing the idea of World Health Organization as well as following the template set by the WHO Health Organization's Alma Ata Declaration. However, at that point of time, it was limited only in the urban areas. By the year of 1985, it was renamed as Universal Immunization Programme, where the expansion of this immunization coverage was now extended to the rural areas as well. Keep this in mind that this Universal Immunization Programme being implemented by the Ministry of Health and Family Welfare is an entirely central sector scheme. Now some of you may will argue that, sir, but the healthcare or the public health is a state subject. We are basically referring to the 7th schedule now. We have learned all the items in the union list, state list and concurrent list. The entry 6 of the state list actually deals with public health. So how such program which is actually dealing with such large scale immunization program and thus actually following the directive principle of state policy article 47 which direct the state to improve the public health care, then how this program can be entirely centrally funded? The answer to that is entry 29 of the concurrent list, which actually directs the power to the central government as well to prevent such contagious diseases from one state to another, under which the government under this Universal Immunization Program basically provides the vaccine for almost 12 vaccine preventable disease at no cost at all. 11 are actually available at the national level, like for example, diphtheria, pertussis, tetanus, polio, measles, rubella, rotavirus, hepatitis B, meningitis, various kind of tuberculosis, or pneumonia which is caused by influenza type B. Then, for one specific vaccine preventable disease, the vaccines are available at the endemic district of various states. Like for example, the disease is Japanese encephalitis, and for that purpose, the vaccines are provided in those districts and in those states where this particular disease prevails or is spread in large number. For example, the northern states like UP, Bihar, Jharkhand, West Bengal, or for example, the southern state belt of Tamil Nadu and Karnataka, or for example, the northeastern states like Assam, Manipur, and Meghalaya. Thus, if you will actually refer to the Ministry of Health and Family Welfare's website, they basically say that how under this Universal Immunization Programme, which has been further strengthened under the Indradhanush framework which was launched in 2014, they are basically targeting 3 crore plus pregnant women and 2.7 crore plus newborns annually. And if you will actually refer to the Economic Survey 2026, it is all in the praise of the efforts of the Ministry of Health and Family Welfare. And for that purpose, it actually showcases a lot of data. It tells us that how India's maternal mortality rate, which is defined as the number of maternal deaths during a given time period per 1 lakh live birth, has actually declined to 93. And from the year of 1990, in the last 3 decades, we have actually registered a decline of almost 86%. Then there exists a 76% decline in the under 5 mortality rate as well. Under 5 mortality rate, which refers to the probability a newborn would die before reaching exactly 5 years of age, expressed per 1000 live birth and not 1 lakh. Here also, the global decline in the last 3 decades was 61%, while we have registered a higher 78% decline. When it comes to the infant mortality rate, there is only 25 per 1000 live birth, which is actually taking place right now, which was actually 40 in 2030. Then there has been a 70% decline in the neonatal mortality rate, 54% globally. So even here our average is much higher, which was actually registered or achieved globally. What is neonatal mortality rate? It is basically defined as the number of deaths during the first 28 completed days of life per 1000 live birth. So keep this in mind that if we'll talk about the children, the base year will always be 1000 live birth. However, if we talk about the maternal mortality rate, there actually the base year or base number is taken as 1 lakh live birth. Take. The same economic survey also gives you a specific table about the UWin portal, which is a user-friendly platform that actually enables seamless access to immunization records, flexible scheduling, and anytime access and anywhere vaccination. According to which, there has been more than 14 crore plus registered beneficiaries and almost 1.62 crore institutional deliveries has been achieved, with vaccination doses administered to approximately 60 crore people. All of this data can actually kind of substantiate your points in your mains answer. However, there are small counter arguments as well from the economic survey. It says that how there are certain states which actually have a very high maternal mortality rate which still prevails in the year of 2026. For example, Madhya Pradesh, where it is approximately 175. So out of 1 lakh women who are actually giving birth to the demographic dividend of the future, 175 of them actually ends up dying while giving the birth to the next generation. Or how 75% of the pregnant and lactating mothers have insufficient calorie and protein intake. So keep this in mind that even after achieving all of these salient features and salient achievements, there are still certain persisting challenges. What are the challenges? Let's try to assess them in the number first. So as per the UNICEF's State of World Children Report of 2024, childhood immunization in our country has actually declined for the first time in the decade. However, we can also counter argue here that because our total fertility rate is also declining, now there are less number of children who are being born per the average size of family. So maybe that is the reason. Second, as per the World Health Organization, India now has 1.6 million zero-dose children in 2023. So approximately there still exists 16 lakh people who did not got any kind of immunization at all. And if we refer to the National Family Health Survey 5, only 76% children were fully immunized. So there are a lot of children who have not got the complete cycle of vaccination doses. Why such challenges persist? Let's try to assess now the underlying factors for them. So, first and foremost, the UNDP report of 2024, it actually first and foremost applauds our country's vaccination efforts and immunization efforts. It says that how 93% immunization coverage has been achieved by India. What does this number implies? So let's say there are 100 children and women who actually falls in the eligible cycle for the vaccination doses. We have actually ended up providing or completing the entire vaccination cycle for them for almost 93 out of them. So that is indeed a commendable effort. But the same report also highlighted the persisting challenge of local inequalities, where there still exist small pockets with low coverage. So it highlights that how out of the remaining 7% population, majority of them actually comes from the marginalized communities. Like for example, they belong to scheduled caste or scheduled tribe, or they are basically the migrant families who are basically migrating from the underdeveloped rural region in the search of job to the urban areas. Or for example, these are basically those factories which are families which are actually living in extreme poverty. So if we corroborate this 7% missing people from the vaccination list and corroborate this data with the Economic Survey 2026, which actually tells us that how 5.3% of our country's current population still lives in extreme poverty. So, which is a person who is actually considered to be extremely poor? The Economic Survey 2026 refers to the World Bank definition, according to which if there exists a person who is actually earning less than $3 per day, then that person is actually considered to be extremely poor. So with the current currency exchange, it will fall approximately to 270 rupees per day. If you are earning less than this, like me for example, then you will fall in the extreme poor category. It's very obvious that such people who are living in this extreme poverty, they do not have adequate resources to actually access such vaccination cycle, or they might not be living in the vicinity of such sound health infrastructure. That can be one very important reason. Or they might not be having actually a good health education to make them aware about the kind of the benefits which vaccines provide, leading to the vaccine hesitancy. This is one side of the coin. The other side of the coin is the complacency which actually prevails in the population. So in this context, just recall the kind of the number of good hygiene and sanitation practices which we very quickly adopted during the time period of the COVID, and how quickly we have discarded them altogether as well. This has been termed by the health experts as the short-term memory effect, where there is a large scale population which do not complete their entire vaccine doses cycle and thus end up paying high out of pocket expenditure on preventive healthcare or on curative healthcare instead of actually focusing on preventive healthcare through the cycle of vaccination. For example, for this also we can actually take the World Health Organization data itself. It tells us that how Indian families, they actually pay 30 to 40% of their total health expenditure from their own pocket. How such large scale out of pocket expenditure actually ends up kind of pushing 60% of such marginalized families into the basket of poverty. Then in our country, there exists the poor state of primary healthcare infrastructure. For which purpose we can actually refer to the data which was provided to us by the Rural Health Statistic 21 published in the year of 2023. Just look at the government healthcare centers shortfall which prevails. If there is a necessity of let's say 25,000 rural primary health centers, there is actually a shortage of more than 1,000 or if there is a need of 21,900 rural community health center, there is almost a shortfall of 17,000 such community health centers. Keep this in mind that the kind of the doses or the vaccine doses which we are discussing, diphtheria, pertussis, tetanus, rotavirus, these vaccine doses are available in these community health centers. So if there exists such a large scale shortage of infrastructure, don't you think that the vaccines will not be able to reach to the people at the first place? Then let's say such infrastructure actually exists in the form of bricks. Then there exists 67% sanction post of specialist at the community healthcare centers in our country actually lies vacant. Just look at the large scale vacancy which prevails across the dynamics of the healthcare when it comes to our country. So don't you think that the Alma Ata Declaration's idea that how there shall be more impetus on primary health care, that actually stands jeopardized in our country? Then, if we refer to the very recent data which was actually published in the Center for Monitoring Indian Economy, it told us that in the time period of 2025 to 2026, if we take one financial year, the total investment which came from the private sector, private capital investment or private equity in the health sector of our country, it was a meager $5.3 billion. So, the kind of the investment which is being made by the government, it is not having a kind of an equal crowding in effect from the private share. At the same point of time, don't you think our government is also trying to follow the fiscal consolidation path? So obviously the kind of the share of the government is actually going to decline in the long run. Next, the low capacity building at the grassroots level. So who actually provides this vaccine to the children and the women at the grassroots level? The Anganwadi workers, the ASHA workers, who are actually paid meager salaries. They do not have any social security coverage. Even during the COVID pandemic time period, they actually face something called as, kind of the driver of the disease syndrome, the kind of the taboos which are associated with them, leading to further vaccine hesitancy or complacency. So what can be the ideal way forward in front of us? First and foremost is to actually expand the components of Indradhanush and actually include such mandatory vaccination, how it was made mandatory in the region of UK in year of 1853 itself, to actually make it mandatory under the different schemes, health schemes of the government of India, such as for example Janani Suraksha Yojana as well as Pradhan Mantri Jan Arogya Yojana or Ayushman Bharat scheme. The second is that first and foremost, many of the people have actually complained about the kind of the after effect which they faced after the COVID-19 vaccine. So there shall be a research based recommendation. There shall be a kind of a detailed research and a lot of trial and error, and then only such vaccines shall be brought to be actually made available to the public. Then, from our National Education Policy 2020 itself, following the model which is actually followed in the Finland and Norway, where the children from the very school age, they are actually made aware about the preventive healthcare. And from the very childhood, that how such vaccination, how taking care of your health, how actually maintaining a good body mass index, how not to actually eat a lot of fast food, adulterated food. So we can actually start doing social engineering from the grassroots level. Then for the faster development of such vaccination, don't you think we can actually use artificial intelligence and machine learning? In this case, just recall the AlphaFold of Google, how they have actually, kind of developed a whole genomic structure by doing the protein analysis of, kind of million of people. So we can also create such database, also use such artificial intelligence and machine learning for the faster development of vaccine. And then we also need to provide an essential program on immunization with equal funding coming from the private as well as the public share. One good news coming in this direction of immunization is that how very recently our health minister actually launched the indigenously manufactured tetanus and diphtheria vaccine at the Central Research Institute in Kasauli, Himachal Pradesh. The launch, which marks a significant step towards safeguarding the national health security and also strengthening our country's public health infrastructure. So I think a kind of a hint for your conclusion has been provided, and with this we move to the next news.